Hello, my name is Justin Beard, and I'm in the FSUJ BSN nursing program. And today, for our Module 3 presentation, I'm going to discuss conflict, delegation, and a healthy work environment. First, let's talk about a scenario that has to deal with patient conflict. We're going to discuss an issue with patient assignment in this scenario. The charge nurse in an ICU has put together an assignment for the night shift. The nurse Sarah comes back after 3 nights off. She's upset with the charge nurse Tiffany because she has an open bed for admission. Sarah tells Tiffany she always gets an admission and does not agree with the patient assignment. A couple of terms we're going to define are conflict negotiation. Conflict is internal or external discord that results from differences in ideas, values, or feelings between two or more people. Negotiation, this oftentimes resembles compromise, and we use it as a conflict resolution strategy. In negotiation, each party is giving up something, and this strategy places emphasis on accommodating the differences amongst the different parties that are in conflict. So we're going to look at conflict resolution through negotiation. We're going to look at the before, the during, and the after. We're going to go through all those steps. We're going to discuss how those steps individually help in the conflict negotiation process, or the conflict resolution process, I should say. And then I'll discuss how I would personally handle the before, the during, and after process of conflict resolution. So first, we want to be prepared mentally by having done our homework. There's nothing worse than trying to jump into a situation or try to resolve an issue that you didn't take the time to figure out what's going on, or didn't take the time to figure out what the issue or problem is at hand. You want to determine the incentives of the person in which you're trying to negotiate with. Not everyone is the same and feels the same way about particular things. There are different ways to resolve things with other staff members. Some staff members, if you tell them, hey, I'll let you pick up a shift. If you just take the staffing assignment, hey, I'll let you take the one-to-one next TPA patient we get if you're able to pick that patient up. Everyone has different things that are incentives for negotiating. Next, though, determine your starting point, your trade-offs, and the bottom line. Figure out what's going on with the situation. Know why you set up that staffing assignment, and how things would turn out if they didn't take that patient load, and get to the bottom line of why they're taking the patients that they're taking, why they have the open bed. Next, you want to look for hidden agendas, both your own as well as the party member with whom you are negotiating with. You want to make sure that the assignment you're making isn't out of spite or malice, and that they're not coming at you because they don't like you for some other unknown reason. So for me specifically, I'd evaluate the assignments that I previously made and see how often Sarah truly did get an admission. And since she doesn't like getting admission, she had a few days off, so she's going to have another shift tomorrow. I'd see if she can get an assignment that did not involve her getting the admission for tomorrow. I couldn't make any promises, but I'd do my best. Then I'd piece together specifically why that particular assignment was put together. I'd look at the benefits of that assignment. I could tell her, hey, since you're getting an admit later, then we'll knock everything out. The patient will be bathed, and we'll get their weights, and we'll do all the interventions, and you don't have to worry about anything else. And when you come back tomorrow, you're already acquainted with the patient, so it'll be easier. They'll be easier to manage and take care of. They're not new to you. I'd ensure that the assignment isn't being put together out of spite or malice. So I'd look at any internal issues how I may feel about the individual, and make sure that there's no conflict or any hidden agendas or anything going on with that. During in this phase, you should maintain composure. You want to be assertive, and you want to ask for what you want. You need to be a role model, displaying good communication skills, speaking skills. You want to be assertive and flexible. You want to maintain composure and look calm because you don't want people to take advantage of you. You want to be assertive for the same particular reason, and you want to speak well and listen well. People will tend to listen to you more if they feel that you are listening and that their voice is being heard. And you got to be flexible. They got to know that they can work with you. Otherwise, they're less likely to compromise. You want to be patient and take a break if either party becomes angry or tired during the negotiation. If you're becoming emotional, it's less likely that you're going to hear them out. If they become emotional, it's less likely they're going to hear you out. You want to avoid using destructive negotiation techniques, but be prepared to counter them if they are used against you. We'll discuss those in a little bit. So I would stay calm and relaxed, and that'll help me understand what they're saying more, and then they'll see that I'm being attentive, and they'll be more receptive. I'd tell them I wanted them to take the open bed, because after analyzing the shift assignment and seeing who was working yesterday, I'd probably find that all the shift members that are working this evening, they worked last evening and they wanted all their patients back. So it's only fair they get their patients back if we've had them, they're acquainted with them. They were here and this nurse wasn't. I'd listen to them and let them know that I would try to not give them the open bed tomorrow and give them their patients back should they desire them. And also that when they get the admit, I'll help them as much as I can. We can knock things out. If the nurse was angry, I'd let them blow off steam. If I were angry, I would allow myself to blow off steam as well. And then lastly, I definitely try to avoid the destructive negotiation techniques, because then people won't be open to working with you and resolving the conflict and negotiating with you. And so the 3 destructive techniques for resolving conflict that I'll discuss, it's 3 that I'd like to name off. Ridicule, which would be intimidating others involved in negotiation. Using ambiguous or inappropriate questioning. This can be used as a diversionary tactic to offset the conflict at hand. It's just pretty much like asking a question or saying something inappropriate that isn't really relevant to the conflict, or that kind of throws things off. For example, like, if you're like, oh man, I really don't want to get this admission, I hate being the open bed, and then you were just to brush it off by, oh well, I hope they call and report for you, so it'll make it easier, rather than just bringing the patient straight up. It doesn't really help, and it kind of seems like you're trying to brush off their concerns. Flattery, this is a difficult one. The individual being flattered, it can make them more reluctant to disagree with the other party in negotiation, and this is also another diversionary tactic. A lot of these destructive techniques in regards to resolving conflict are very manipulative. So you want to make sure you're not using them, and you want to be on guard for them as well. And then so now we're going to look at delegation, and we're going to start this off by looking at a scenario where a patient in the ICU is going to cardiac arrest. So in the ICU, patients going into cardiac arrest is not uncommon. Let's say you have a 73-year-old patient that has developed chest pain, and they drove to the ER. The patient gets an EKG. It shows ST elevation myocardial infarction. The patient's emergently brought to the cath lab. They had 100% occlusion of the left circumflex artery and 90% occlusion of the right coronary artery. So they get 2 stents placed, and the patient's brought up to the ICU post-procedure. They're waiting waiting times for the full code, and the nurse is doing the admission history, and that's after a physical assessment was conducted, and the patient was answering appropriately. Then they began agonal breathing. The nurse checked for a carotid pulse, none was present. They tried to shake them and see if they'd respond. They didn't do anything at all. So the nurse hits the code blue button. You have the intensivist, they come running in. You got the respiratory therapist, the PCT. You got a whole bunch of nurses. One of them spraying in a crash cart. And then the intensivist asks one of the nurses, hey, check for a pulse. They confirm there's no pulse. So the nurse orders nurse 1 to record, nurse 2 to connect pads and leads, nurse 5 to start chest compressions. And the intensivist, after the leads are connected, he sees that the patient is in VFib, so he charges the defibrillator 220 joules. He tells everyone to stand by or stand clear, and then shocks the patient. The patient's still in VFib. The intensivist orders nurses 2 and 3 to turn the patient, and for 4 to slide a backboard under the patient. Nurse 2 then begins to do chest compressions, while the respiratory therapist stand ahead of the bed with the bag valve mask, doing rescue breaths. The intensivist orders nurse 3 to drop medications and 4 to administer them. Nurse 5 is on standby. They're switching with compressions. When the nurse 2 that's doing the compressions, when the intensivist seeing that they're too fast, not deep enough, he just tells them to swap out with the standby nurse. And then after nurse 3 draws up 1 milligram of epi after he tells them to, they hand the syringe off to nurse 4. and then they're about to inject it without even flushing the IV. So the intensivist tells them, hey, flush it, make sure it's patent, it's leaking. So then the nurse ends up flushing a different IV. That one's patent as opposed to the other. And so they administer the 1 milligram epi, and they say 1 milligram epi given. Intensivist asks nurse 1, the reporter, if 2 minutes are approaching, and then that nurse is like 2 minutes and 10 seconds have passed by. So the intensivist tells everyone to stand back and tells nurse 5 to check for a pulse. So they do a pulse check. Everyone looks at the monitor. The patient's now in sinus rhythm. Nurse 5 calls out they have a pulse, and the respiratory therapist is that the patient is breathing on their own, and ROSC has been achieved. I know that was a lot to take in. But looking back at it, let's define delegation, and we'll discuss in regard to this situation. So delegation is getting work done through others or directing the performance of one or more people to accomplish organizational goals. So with this situation, we're going to look at the five rights of delegation, and we're going to discuss how they apply to this particular circumstance. So we've got the right task, which is one that is delegable for a specific patient, the right circumstances, which is the appropriate patient setting, available resources, and other relevant factors considered, and the right person, which is the right person delegating the right task to the right person to be performed on the right person. So with the right task, there's no doubt about the nurse calling out code blue for the patient. In this given circumstance, I mean, the patient was alert oriented, then they began agonal breathing, they became unresponsive, they didn't have a pulse, so this would indicate the need for ACLS. The circumstance was right because the environment was not a dangerous one. They were not out in the field, they were in a puddle of water while there was lightning. They're not in a building that's on fire. They're in a safe, contained environment, and the resources are also available, as every unit in the hospital has a dedicated crash cart for emergency situations and for code blues. The right person. The individual delegating the task during the code was the intensivist, whom is oftentimes a doctor, nurse practitioner, or physician assistant. They are ACLS certified, and the patient was identified as being in cardiac arrest. So look at the other two. Right direction communication, a clear, concise description of the task, including its objective, limits, and expectations, and right level of supervision, which is appropriate monitoring, evaluation, intervention, and feedback as needed. So with the right direction communication, given the following circumstances and how the patient was experiencing a cardiac arrest, concise descriptions of the task can't always be given in such an acute situation. In any ways, in order to carry out BLS, or Basic Life Support, or ACLS, you have to take a certification course, and you have to take an exam, and then you can get certified. So the staff should already have some sort of general knowledge of their tasks and duties. I mean, they may be a little bit rusty, and it may be a while since they've done it, but they should have some general knowledge. If they're uncomfortable carrying out a task, they should let the delegator know that they don't feel confident in conducting that task, or the delegator or another nurse can give them some guidance during a task that they may feel uncomfortable with. Sometimes you have to step out your comfort zone, and that's what growth is. So sometimes they can delegate you they can instruct you in real time, depending on the given situation. So looking at the right level of supervision, in this situation, the intensivist was monitoring the code, and he was intervening where he thought was necessary, but he had moments that were better, more adequate feedback could have been given, and we'll touch up on a couple of issues with that in a little bit. So looking at ensuring appropriate delegation, this is how I ensure that delegation of each task is appropriate. I would see if I'd ensure that the staff member was licensed or able to carry out the specific functions being delegated. I'd see if the staff member was competent and confident enough to carry out the specific function safely. And then I'd see if the task is appropriate and at the level of the staff member's competency, or whether it was below.